Because I have encountered postmenopausal women with estradiol levels in the 200s.
Okay.
So that is a woman that may be heavily symptomatic, but absolutely needs a workup before initiating hormone therapy. And then if it's still high, then you need to be evaluated for some type of estrogen secreting tumor.
Okay.
So labs play a big, big factor.
So I'm so excited to have you on my mini podcast,
Mhm.
Monica. I have known you for more than 20 years now.
Mhm.
So I knew you when you were a student at Shenandoah University, and now you've gone through almost 20 years in the emergency room, and then almost 10 years in your own practice.
Mhm.
Can you tell me a little bit about your practice and your interests and what drove you to start this practice?
Yeah, so I own Loop Wellness Clinic, and my main office hub is in downtown Leesburg. And really, I started Loop because I knew that I wanted to do more for patients. As you illustrated, my background was in the emergency room, and I did value every single year that I was in the ER, and but I did. So you also know me personally, and I think, truthfully, I practice the way you practice, and because I remember shadowing in your practice, and I remember it was you were always like 15, 20 minutes behind.
At least.
Spent so much time in each room, and I remember, Scott used to always be like, "Oh my God, tell Shyama to hurry up." And so, but that's how I practice, and that does not bode well in the emergency room. And so I did love the interactions with the patients, and there is not continuity of care in the emergency room. And so, um, I originally, my goal, like I started in the ER because I thought, this is really going to give me just a good foundation of medicine, and really I should be able to know a lot about everything, and so my intentions were, let me start in the ER, and then I end up loving it, and I stayed, but then truly the desire to want to do more for patients and have the continuity of care started to kind of supersede what my goals and desires were. And so that just started the journey, so to speak, of trying to figure out what did I want to do and how did I want to serve patients and serve the community. And I was always interested in health and wellness, and in kind of like longevity of life, and trying to guide and educate patients on how to get off of all of these medications that they're on. And so that just started the process of research, and what did I really want to do, and how did I want to spend my time, and how could I serve these patients. And so, so I knew that I was going to open up my own practice. I knew that I really didn't see myself doing like primary care or internal medicine. And so that started the journey of like, okay, well, how can I do health and wellness and longevity, and I had an interest in hormones, and I had done some independent research, but I wouldn't say I was a novice. I didn't know a lot. I I found the most wonderful mentor that has since passed away, but and he really took me under his wings, and he had a hormone clinic in Chesapeake, Virginia. And so I spent over a year just driving to Chesapeake, and I was really just enamored, and I learned as much as I could through him, by him, and then I did my own training. And so that is what kind of led me to opening up Loop. So when I met him, his name was James Cannon. When I met Dr. Cannon, and I spent one day in his practice, I knew that this is what I'm going to do. And so then I spent that year training to kind of build myself up to opening up Loop, and really offering hormones as my primary staple for what the practice stands for.
And I think I heard you say, Monica, in a previous interview, that what helped you make that decision was what his patients were saying when they came out to talk to you, the impact they were saying that hormone therapy had on their lives.
Yes. I will tell you that was so. I'm going back to over 10 years ago. And so when I went into his practice the very first time, so and I did not know Dr. Cannon. Like we stumbled upon each other really by fate, and he was just so he was so knowledgeable, and he was a PA, PhD, Navy pilot. He had all this experience, and he really just advocated for mid levels. And so he spent a couple hours on the phone with me, just really kind of guiding and educating me on what I wanted to do and what I foresee myself doing and how I wanted to help patients. And then he invited me to join him in his practice. And he said, I really do think, listening to, what your goals and desires are, I really do think that you should come and just shadow me for a day and see how my practice operates and just learn a little bit more about hormones. And I drove up there thinking, okay, this is just going to be a couple hours and I'll be in and out. And oh my gosh, like it was so profound. He had 30 patients scheduled for the day. He cranked out patients in and out. And I am not exaggerating. It was every single patient was saying, this has been life changing. Dr. Cannon has changed my life. I feel amazing. I used to go to my doctor for these complaints and I got nowhere. And it was almost like he knew I was coming, so he set up the stage of like, oh, let me bring in like the top
All
30
the
patients
patients. Okay.
that are gonna like try to really advocate for her to start a hormone practice. But truly, it was that is just how every patient felt, and they knew that how he introduced me. They knew that I was kind of learning about hormones and was considering it, offering it. And so they wanted to just, they felt like they had 2 minutes to like tell me everything. Like, oh my gosh, this has been life changing. Oh my God, you really should do this. Where are you based out of? And so it was eye opening. It truly was. And it truly made me feel like, okay, wow, where has this been? Why, as a provider, why do I not know about this, and why do our patients not know about this? And so that really sparked this desire to just say, this is what I want to do, and this is I want to advocate for patients, and I want to help patients, and I want to be able to offer this to them, and I want to do it safely, and I want to do it responsibly, and I want to know everything that I can about hormones so that I can do this in the right way. And so that is how this all started.
That's amazing, Monica. And so even though I know that your office does more than hormone therapy alone, but specifically for the hormone therapy, can you tell me a little bit about the different types of hormone therapy that you offer?
Yes. So I treat both men and women.
Mhm.
And predominantly, the hormones that I look to manage for men are testosterone and thyroid.
Mhm.
For women, the potential for testosterone, estrogen, progesterone, and thyroid. So those are the hormones, and then it's really based on every individual, and a lot goes into determining what is the right hormone for you, which ones should we initiate, and then in which manner do we want to administer those hormones.
So you're using their clinical symptoms as well as blood work to help guide you?
Yes, so it really is a combination of age,
Uh-huh.
clinical symptoms,
Uh-huh.
labs,
Uh-huh.
and medical history, and
Okay.
even family history. So all of that plays a factor into what we're going to do, and how we're going to do it.
Okay. And can you tell me specifically what in the labs are you looking for to help formulate hormone replacement
Sure.
therapy for the
So yeah. So it depends on when I'm looking at the labs. It does depend on your age, and it does depend on whether you are in perimenopause or whether you are in menopause.
okay.
And so that plays a factor into then how you analyze those labs to then determine what are you a candidate for. And so for example, let's use there's a lot of ways that you can do this, right? So There are places that don't necessarily evaluate labs prior to initiating hormone therapy.
Mhm.
And so taking that into consideration, right? If I have a woman that is in menopause, has been in menopause for years, and I choose to not do labs and I'm going to go just based on clinical symptoms. You're 64 and you have hot flashes, still you have some night sweats and you really have bad vaginal dryness. There are some practices that think, okay, well, you're in menopause. Let me just initiate a very low dose of estrogen, not vaginally, like systemically. And why don't we just start there and see how we do with your symptomatic benefit, and then we'll possibly check some labs after. And so, where labs play a huge factor in this is you're in menopause. You should not have any circulating estrogen. Granted, if you're overweight, you might have some element of estrogen, not because you're producing it, but just because it's in your fat stores. But if I have encountered scenarios like this where had I not checked labs, there could have been really some detrimental outcomes because I have encountered postmenopausal women with estradiol levels in the 200s.
Okay.
So that is a woman that may be heavily symptomatic, but absolutely needs a workup before initiating hormone therapy. Needs I do a different type of serum analysis, and so for that woman with a level in the 200s, and this has happened actually a couple of times, and so then it's determining A, is this a lab error? B, we need to do a more expensive estradiol LCMS test, and then if it's still high, then you need to be evaluated for some type of estrogen secreting tumor.
Okay.
So labs play a big, big factor in where you are in your stage for a woman specifically, where you are in your stage of life plays a factor too. And so if we use a scenario with a perimenopausal woman, um, once again, there's a lot of places that are thinking we can do very, very low dose of estrogen without checking labs, thinking that low dose is benign and not a problem to initiate prior to checking labs. But same thing, when you're in perimenopause, your estrogen levels are going to vacillate. And so if you check, they might be really low. And if you check, they might be really high. But if you happen to catch a perimenopausal woman that has hot flashes and night sweats and her estradiol level happens to be 400, that's not somebody necessarily that you want to initiate estrogen right out of the gate because so clearly, when she spikes, she can spike really high. So then adding estrogen in that particular patient might induce estrogen dominant symptoms. So it's an intricate balance of what you do, which is why it's really important to go to somebody that is experienced and somebody that does know really what you should be doing rather than somebody that is kind of dabbling and wants to start hormones without doing a baseline lab evaluation.
So to be honest, I have been practicing for 30 years, and so I'm not necessarily dabbling, but I'm not focused on hormone therapy in my practice. But I don't do a lot of blood tests, so I, want to be clear for people that are listening that people have different practice styles.
Mhm.
Um, I do some blood work before I start hormone therapy because I'm looking to confirm that a woman is in menopause. But I would probably miss those people that have estrogen secreting tumors potentially. But just a little bit more on the blood test. How are you using the blood test to then guide your therapy after treatment? Because I've had patients come in and say, they'd like to do blood work on hormone
Mhm.
levels, which I'm testing estradiol, testosterone,
Right.
progesterone, FSH, and LH. So I've had some women who have come in and want to do more frequent hormone
Mhm.
testing. How are you using, once you've decided, and let's take the menopausal group, once you've decided that you're going to do hormone therapy, how are you using the test to then alter your treatment?
Sure. So
Adjust it.
it's based on then how high are their levels.
Mhm.
And so then that goes backwards to what modality are you using? to take that into consideration with timing of lab draw.
Okay.
And so the labs now at this juncture
Yes.
are helping you determine, are you on the right dose? Because it's not always about symptomatic relief.
Uh-huh.
So if we use estrogen as an example, so when when you're in menopause and you're managing somebody with estrogen, essentially their levels, if you're doing let's say you're doing pellet therapy, okay, your estrogen levels are consistently elevated for maybe a 2 to 3 month window.
Mhm.
So when you're doing labs, what you're trying to ensure is that that estradiol level is not astronomically high
Mhm.
for that 2 to 3 month window.
Mhm.
And so if you don't have a uterus, we're not worried about vaginal bleeding.
Mhm.
Still, that woman should not live with her estradiol levels up here.
Mhm.
If you think about it like this, you're trying to somewhat simulate what your body did when you were pre-menopausal,
Menopausal. Mhm.
and your estrogen levels never lived high. They
Mhm.
only spike high,
Mhm.
kind of midway through your cycle.
Mhm.
And so, just because you're in menopause and you don't have a uterus, it does not mean that we still shouldn't try to simulate a higher level, but just at a consistent baseline, opposed to a high level in the hundreds.
Okay.
And there has been research that states that high octane estradiol levels
Uh-huh.
increase risk of carotid stenosis.
Okay.
So really, you're just trying to track and monitor how high are those levels versus how low are those levels. Are you absorbing?
Mhm.
And so if you're doing creams, you're doing patches, the labs help from the standpoint of absorption.
Mhm.
And so timing then is really important with your lab draws,
Uh-huh.
because if you're on a patch that you're changing midweek,
Mhm.
then really it's about how detailed do you want to get with this patient and how important is that lab value? Because truthfully, then you're really supposed to check the labs. If you're trying to get peak value, you're trying to check it like, a day and a half after patch application.
Yes.
So that's how I use the labs to really guide, are you too high or are you too low? And
So so
Mhm.
clinical symptoms can help you determine if they're too low, but then the blood tests help you decide if they're too high, in a sense. Because if they're clinically feeling like their symptoms are adequately treated, then you know that then you don't necessarily need to get like the low levels like before the next patch, say. But if
I
you're
I've
high, you may not know.
I've encountered both, to be
Okay.
honest.
Okay.
So I've encountered patients that their levels um, are higher than I would like them to be, but yet they still have symptoms.
Mhm.
And so then it's trying to navigate, what else can we do, what else can we add, to help resolve those symptoms. So it's not always about let's dose increase,
Mhm.
even if you're still symptomatic. And that's
That's
very
correct.
reflective of testosterone as well. So when you're managing with testosterone and you have a patient that still comes in and says, I still have X, Y, and Z symptoms, the answer isn't let's dose increase.
Mhm.
It's let's reassess.
Yes.
And even we could take hot flashes, for example. For a woman with hot flashes, it doesn't mean we need to dose increase. It also could mean let's go through your history. Are you only experiencing hot flashes at night? Are you only experiencing hot flashes when you're drinking alcohol? Like there are triggers
Mhm.
also.
That could be.
So it's not always about we need a higher dose.
No, no. What I was saying is that that the a trough level isn't that helpful if so a low you're not looking as much for low levels of hormones if clinically their symptoms are being met. So people come to us because they're symptomatic from perimenopause or menopause.
Hmm.
So say we initiate therapy. If their symptoms are being corrected, meaning they're no longer having hot
Hmm.
flashes, vaginal dryness is better, cognitive cognitive impairment is better, mood has stabilized, maybe libido has improved. So you know their quality of life has improved. So you're not necessarily looking even if their level was low, but their symptoms are resolved, there's no reason or indication
Correct.
to
To go
increase.
up on dose.
Yes. But
Absolutely.
But even if they are feeling well or still having symptoms, I understand that you would use the levels to help prevent you from taking them from an already high level blood level to a more toxic level.
Correct.
So that makes sense.
Yeah. But
Does
yes,
progesterone?
so to answer that question, then yes, like if they have symptomatic relief, I'm not looking to dose increase,
Yes,
especially if levels look low.
even if
And also it also, when we say levels look low, it's reflective of did we check labs at an inappropriate time frame to gauge, are you low?
Mhm.
So no, I don't necessarily dose increase if they have symptomatic relief.
And so we talked about estrogen and testosterone levels being valuable. What about the progesterone level?
I I don't find progesterone levels to be
Helpful.
so helpful. And that's patients. A lot of patients really love to see their levels, and they don't love when you say it's really not the most accurate.
Uh-huh.
But that is the truth. And so if I have a woman that I do have on higher doses of progesterone, and especially if it's a woman that has had some issues and is bleeding, and we have them on higher doses of progesterone, I always check progesterone levels, and unless that level is just really sky high, then will I kind of scale back. But usually I find progesterone to be not as helpful.
Okay. And since we mentioned a little bit about uh, menopause and perimenopause, tell me how you approach a perimenopausal woman different, because the biggest distinction for me is menopause is defined by clinically by absence of a period for 12 months.
Hmm.
Um, at that point, you're no longer ovulating, so you're no longer at risk of pregnancy. Perimenopause, however, you are having irregular cycles
Hmm.
and maybe having all of those other life disturbing symptoms.
Hmm.
Um, but you are also at risk of pregnancy, and your body is still making some hormone
Hmm.
itself, some more hormone itself. So how do you treat differently in the perimenopausal group?
So, as you said, in perimenopause, you're still producing estrogen, you're still producing progesterone, you're just not producing it at a consistent variable amount or time frame. So, my approach really is testosterone can manage the majority of complaints that patients have.
Interesting. Okay.
And so, estrogen, when you're in perimenopause, estrogen is used for symptomatic relief only. When you are in menopause, estrogen has two roles, which is symptomatic relief and then protection, because your body is now no longer producing those hormones. So we're not necessarily worried about the protective component of estrogen in perimenopause because you're still producing the hormone. And so majority of the time in my perimenopause patients, I initiate testosterone first, low dose,
Mhm.
and that for the majority of the time will resolve vasomotor complaints. And helps with so much more that estrogen doesn't necessarily provide benefit towards. And so I am slow to initiate estrogen in my perimenopause women. A little quicker to do vaginal estrogen if vaginal dryness is one of their complaints, but and testosterone is and testosterone can help with vaginal dryness, but sometimes it really boils down to the significance of the complaints. So if I have a woman in perimenopause that is 51, 52, and has 20 hot flashes a day and has so significant vaginal dryness that she cannot be intimate, that is a patient that I will likely initiate estrogen and testosterone, because we're likely not going to be able to navigate all of her symptomatic benefits just with testosterone. So age and significance of complaints plays a factor even still when you're in perimenopause. But the younger population of patients in in the 40s, you usually can navigate with testosterone first and then add. And usually my approach and guidance with patients is that this is not a race. This is a very slow marathon,
Mhm.
and so we have to move slow, and not throw everything at you at once. And most patients are very receptive to that.
Yeah, I think for so many women who haven't been heard, whose complaints haven't been heard for so long, despite going to medical providers, I feel just the relief of knowing somebody is trying to work with you and help
Yes.
you is a huge hurdle. So can you tell me a little bit about, you do different types of hormone replacement, different from each hormone, but different modes of delivery.
Yes.
Can you tell me a little bit about the different modes of delivery and how you select one versus the other for different people?
Yes. So I offer testosterone as a sublingual, as a cream, and as a pellet. I offer estrogen as a patch, a cream, or a pellet. So if we kind of clump your sublinguals and your topicals in one category, and we clump the pellets into another category,
Okay.
there are positives and downsides to whichever modality you choose.
And can you
So,
describe what the pellets are?
yes,
Sublingual is under the
so
tongue. Topical
sublinguals.
is either on the skin or vaginal.
Yes, and when it's on the skin, it's either a cream or a patch.
Okay.
And then a pellet. So a pellet is literally a little pellet.
Uh-huh.
It's a bioidentical hormone bound with stearic acid, which is what is in aspirin. And it's placed into your subcutaneous fat. So most of the time it's in like your kind of glute hip region for women. And so it does require a very minor procedure. You use anesthetic, you make a very small incision, and you use a trocar and you place the pellet into the subcutaneous fat. You don't close with any stitches, you just use a little steri strip, put a dressing on there, and it takes about 72 hours to heal. So women heal fast, and women, for the vast majority, find it to be very manageable, and from a discomfort standpoint. So the way that the pellet works is that it takes about a week to form blood vessels around the pellet, and then it basically is broken down based on cardiac output. So once you have the capillaries around the pellet, every time your heart beats, it just kind of flows over the pellet, and you get a slow infusion of the hormone into your bloodstream.
Okay.
And so it usually, for your very first insertion, it takes about 6+ weeks for you to notice symptomatic benefit.
So for the serum, the blood levels to get high enough that you're
You,
consistently feeling benefit.
your blood levels will be high. So they're meaning that if I were to check your labs at 4 weeks, if I were to check you even sooner than that, your levels may be high, but
Uh-huh.
that doesn't necessarily translate to symptomatic benefit. There's
Okay.
usually a lag time with like the testosterone binding to the receptors and for you to really feel the
Okay.
overall benefit. And so it is a slow process, but I would say the same is true even for topicals, that it's not a necessarily an instant gratification. It can take time for your body to respond.
Okay.
And um, but the delivery system as a whole, it bodes very well for compliance, because your treatment for women is every 3 to 4 months. So
Okay.
even though your very first insertion may take 6+ weeks for you to notice benefit, moving forward, you place these pellets in somebody, and within 1 to 2 weeks, they symptomatically feel better,
Mhm.
and they feel good for about 3 months. And then it's a subtle return of symptoms, and that usually coincides with when you're due for another treatment.
Okay.
So in general, the pros really are the compliance. I would say the other pro is that it's your absorption is really good, because you form these capillaries, so it's directly into your bloodstream,
Mhm.
and your levels are consistent for a longer duration. Your downside is that it is a minor procedure, and the pellet is in you. And so if you absorb differently, if you metabolize slower, or you are inappropriately dosed,
Mhm.
your levels will get too high.
Okay.
And so that doesn't always translate to side effects, but it can. And the longer that you are treated with, high doses, eventually you'll have side effects for sure.
Okay.
So you really do have to be monitored and managed very appropriately to ensure that your levels don't get too high. But the pellet is in you. That's the bottom line. And so
Okay.
that can be deemed as a con.
Okay.
When you're looking at your creams and you're looking at your sublinguals, the beauty of it is the fluidity, right? It's so easy, and you can really just dose very low and wait for symptomatic response, and then make changes as we go on kind of weeks of a time frame of reassessment. If you don't like how you feel, if you experience something you don't like, we can scale back. So that fluidity is really nice. Your downside is compliance and absorption. So those are two things that one, the compliance piece. If you know as a patient you cannot remember to take anything, this is really going to hinder our success here and you getting symptomatic relief if you can only remember to dose yourself twice a week.
Okay.
And then even if you are type A and you're going to remember every day to dose yourself, you nor I nor the patient have control over the absorption. And so that can really hinder results. So, how I gauge what I'm going to do for a patient is really, I just come from the platform of, let me just kind of inform you and educate you on the hormones. Let's really talk about what your symptomatic complaints are, and then which hormone, are we even referencing, and just realistic expectations. But then, which hormone we're going to choose is really, truly up to the patient.
Okay.
If you have somebody that is like, I really genuinely am not going to remember to do anything, so I feel kind of deflated here, I really wanted to do creams but I know I'm not going to remember, then we talk about pellets and we talk about what makes them uncomfortable about it, and really kind of just ensuring that low doses of pellet therapy go a long way. So it really is. I defer to the patient, and I give them guidance and education on all three. So I don't hone in only on pellets or hone in only on topicals, so that it allows them to kind of decide which route do they want to go.
Okay. And so when you're getting obtaining like pellets or the creams, whether it's estrogen, progesterone, or testosterone, or the sublinguals or the patches, are you getting them from a compounding pharmacy or a traditional pharmacy, and where do you source it from?
So most of my meds come from a compounding pharmacy. And so the patches that I use come from your traditional commercial pharmacies.
Okay.
And so I've used the same few compounding pharmacies for all of my medications, and one's local in Leesburg, one is in Sterling. But truthfully, it's really just about, is it a 503A or B compounding pharmacy? And so I would tell anybody that's really what you just need to do, your due diligence of like what pharmacy are you using?
Mhm. Can you tell me the names of the pharmacies?
Oh yeah, so I use Strive and
Yes.
I use Akina.
Yeah. So I think those are the two that we've used as well, and they've been great.
They have
Um,
been. I've been happy.
Question for you about the testosterone. So cost is always an issue for all of us, and when we get medicines from a traditional pharmacy, insurance potentially will cover. When we get it from a compounding pharmacy, we have to pay out of pocket.
Right.
And sometimes insurance reimburses, or HSAs could pay for it
Yeah.
if you have an HSA account. Question about the testosterone, because testosterone for men, we do dispense in like a pump or or not patches, pump or packets of creams. Have you found that prescribing it to women, insurance is covering that?
No,
Or no, they're not.
it usually is not. I will tell you that, it's unfortunate.
Yeah.
And so compounding pharmacies do come with a higher price tag for sure.
Mhm.
But you're limited, right? Because you cannot get uh, we don't have the option for like a bioidentical cream at
Yes.
a traditional commercial pharmacy.
Yeah.
And so we're significantly limited. You don't even have the option for bioidentical testosterone at a commercial pharmacy. And so there is really no workaround from that standpoint. So you and then there's even a lot of shortages with your estradiol patches now.
Yes. Yeah.
And so it's one of those things that is unfortunate, and
Yeah.
I don't think there's a good answer
Yeah.
for what to do, but unfortunately, it is compounding pharmacies that we have to use. And you know, even if they were available at commercial pharmacies, the limitation with your commercial pharmacies is that, they are FDA approved as a standardization. And so your standardization is only X number of doses. They can't offer 10 different doses, 15 different doses, because then it would not be FDA approved. It has to be limited and regulated. And so there's limitations with that also. So, when you're really trying to be very unique and specific and dose for a patient based on they're not getting relief with your commercial doses, you need to use compounded.
Yes. That kind of leads me to my next question, which is, um, how do you address the fears that some patients might have when you say compounded medicines are not FDA approved,
Mhm.
compared to the
Yeah.
things that we would prescribe and get at a traditional pharmacy?
So I'll tell you, this is such a good question, um, because I do not think that the general public understands the distinction between where you can get your medications from and terminology and what that means. And so essentially, there are three kind of categories, so to speak, of how you can obtain medications. And the climate that we are in now, it's so important for patients to understand this. And it is their responsibility to do their research and understand this, because there are so many online sources now where you can get hormones and you can get peptides. And and a lot of those fall into that third category. So you have FDA approved, you have FDA regulated, and then you have unapproved sources. And so FDA approved is what you get from your commercial pharmacies, and it has gone through R&D, and so it has been approved by FDA and state due to sterility, quality, efficacy, safety. And so when you are using a compounding pharmacy, it still has FDA regulations. And so that means that it has to be a 503A or B. If it is not a 503A or B, then somebody's using compounding pharmacy as a term, but that doesn't mean that they have FDA regulations. So
Okay.
it's really important for patients to understand that your 503A and B compounding pharmacies are regulated by the FDA and the state. So they still require to fit the bill for safety, efficacy, sterility, and quality. So they still have those same requirements. And when it is FDA regulated, it's still you're not changing the active pharmaceutical ingredient of the drug. You're not changing the molecular structure of the drug. What that compounding pharmacy is allowed to do is legally change the formulation of that drug, change the dose of that drug, and change the concentration of that drug. But you are not allowed to change the physical medication itself and the molecular structure. So I tell patients that it's regulated by the FDA. It is safe to use. And once again, going back to that understanding that hormones truly need to be tailored to every patient, and we would have significant limitations if all we had were commercial options and not compounded options.
Yes.
Now, that third, unregulated, is what is so scary. And that means that patients are being given drugs that have had no research. There's no checks and balance from sterility, safety, efficacy, absorption. It's scary. And so, and I think patients have this sense of comfort when they are even online going to a place and they've been evaluated by a provider or a doctor, and now they're being prescribed medications and they think that everything's great. And this goes back to your comment on price. So if you're paying a fourth of the price of what everybody else charges, there's a high probability that's an unregulated drug and they can charge you the bare minimum for it.
Yes.
So it's yeah, it's that
Yeah.
is I would say a big red flag, and patients should be more aware of the unregulated. And I would say significant comfort in the fact that it's FDA regulated, and it's okay that it's not FDA approved.
Yeah. It is scary. And do you see patients that are coming to you? Do you see many men or women who are doing hormone therapy that have come from providers who are prescribing it through unregulated pharmacies? I worry about it in the younger people
Mhm.
who I see, who I have heard start to mention peptide therapy
Yeah.
and that they're getting it online. But
Yeah.
do you see it in the hormone therapy field as well?
Um, the the truth is I wouldn't know, right?
Okay.
So they come to me and they say I've been on X, Y, and Z. Um, I had a patient, I'll use this as a perfect example. I assume that what she had was not regulated.
Mhm.
She'd been on it for years and she was not getting symptomatic relief. And so, and she still wanted to stick with her cream. And I said, I do need I need to know even like what dose you're on, because I don't have a basis of what we're going on here. And so she sent me a photo of her testosterone vial,
Mhm.
and there was no pharmacy label on it,
Wow.
nor did it have the concentration of the drug. So it said like apply, it said like apply 2 pumps or 5 pumps.
Uh-huh.
And I'm like, take a picture of the back of the bottle, because 5 pumps still doesn't help me with what the dose is. I don't know what the concentration of the vial is.
Uh-huh.
There was nothing on it.
Wow.
And so she'd been on it for years. And
And paying
so
for it for years and getting no symptomatic relief. And
yeah,
yeah.
she said sometimes she did, and now more recently she wasn't. And so, so that's, I would say, do I know with confidence? No, but she couldn't tell me the name of the pharmacy. It wasn't on the bottle, and it just had what she's supposed to apply. So, but a lot of times I don't get the photo. I just get, people saying that I'm using this online source, and I just feel like I get a lot of, I just feel like I don't know. I feel like a little unsafe. I feel like I don't know if they really know what they're doing.
Yeah.
And so could they be using it appropriately from a compounding pharmacy, 503AB? They could, but sometimes you wonder.
Wow. This has been so helpful, Monica.
Oh,
Thank
good.
you. Thank you, even for me, and hopefully for any patients that watch the video.
Yeah.
I think we're all learning, whether we're a provider or a patient. We're all learning. There's new information coming out. There's different ways of treating the same problems, and I think it's important what you also said, that each therapy has to be individualized.
Hmm.
So just because it works for one person it may not work for you. And being able to sit with a provider that will talk about the difference and try to find the solution that fits what you need, I think it's so valuable.
Yeah.
Thank
Well,
you.
thank you. And I know I would say the biggest thing that I would advocate for patients is to make sure that you're heard and to make sure that you're listened to, and to also just they have to do their homework on who they're going to, and research a little bit about where those drugs are coming from, but the provider itself.
Yeah. Thank you very much.
So
And if it's okay with you, I'd like to just include a little link to your practice, because I know you do so much more than hormone therapy. You're doing some treatments for weight loss, treatments for female urinary incontinence,
yes.
and starting to do treatments for, or doing treatments with other types of peptides.
Yes, we are FDA regulated
FDA
peptides.
regulated peptides.
But nutrition, gut health testing, yeah.
Yes,
So
it's exciting.
yeah, it is. It's really exciting. So yeah, but please put my bio down, and anybody that's in my area, just reach out.
All right. Thank you so much,
Thanks,
Monica.
Shyama. Take care.
Bye.